Hello, everyone. Thank you so much for being present with us on this Wednesday. Thank you so much. We also want to say hello and thank you to all those who are joining us virtually. Thank you so much for taking time off your schedule to be with us, and we hope that the knowledge, the information that's going to come through is going to be doing wonders for us all, because we are discussing life-saving matters. And before we can do that, we want to be able to invoke the presence of the one who is ultimate in our lives. I would hope that we, the ultimate one. So we want to say good evening and thank you so much to Father Albert. Father Albert is going to lead us in prayer before we can begin our town hall session. Father Albert.
In the name of the Father, and of the Son, and of the Holy Spirit. God our Father, we thank you for today. We thank you for the gift of life. We thank you for the gift of each other. We pray, Lord, that you open our hearts, open our minds, that we may be able to discuss life-saving matters, that we may be objective, and that we may always look at the needs, the common good instead of our personal good, as we seek to develop new ways, new strategies, new means of reaching out to our people and serving them. We pray in a special way for the management and staff of the Millennium Heights Medical Complex as they continue to serve you in serving others. We ask for all those graces, and we pray in a special way for the Ministry of Health, for the health care of our country. We ask that you bless and continue to improve these services that are being offered through the length and breadth of St. Lucia. We ask this through Christ our Lord. We ask this through Christ our Lord. Amen. In the name of the Father, and of the Son, and of the Holy Spirit.
Amen, amen. Thank you so much, Father Albert. And we are in Father Albert's domain. We are coming to you live, for those of you who are virtual with us, from the Babonneau Multipurpose Center. And this is the third installment in the Town Hall series by the Millennium Heights Medical Complex. We will be discussing the operations at the Owen King EU Hospital, the OKEU, and of course this is going to feature what the hospital, the administration, the management team, the staff, what it is that they're doing to improve healthcare for us all. And also we will be inviting your comments. We would love for you to be able to pose questions so that you can have further clarity as to what it is the OKEU is doing to improve healthcare for all of us. But before we can do that, before work, play is always essential. I love it. I love to play. Do you love to play? I'm not sometimes. I'm hearing sometimes. Okay. Let's make it all the time. Smiles keep us young. So we want to welcome, to give us a little laughter. You know, you have to, I often hear the doctors say that as part of the bedside medicine, that laughter is great for the soul. So we'll be having some laughter with our one of our favorite comedians. Cyril Productions is with us this evening, and if you don't know Cyril Productions, what's that about? It's Cokes. Iglesia is in the house. We're about to have something phenomenal happen. So get ready to put those smiles on, and let's welcome Cyril Productions.
Iglesia fait vite en aller. En aller. Ou toujours, ou n'est pas jo had ka mette en là. En meeting nous ka aller ou hani pyjama ou na bay ou habillé pour demain.
Cokes.
Yes, Iglesia.
Ça qui vaut?
Moi d'où nous ka aller dans meeting ou ka prend combien de temps? Why have you linger in Iglesia?
Cokes.
Oui.
La pas même ni tellement moun ici ou ka rush moi quantité. Toutes ces chaises là still vide. Qu'est-ce ça ou ka dit là?
So we say wait te fait qui ça? What are you staying to do, Iglesia? It's a town hall meeting. Moi d'où nous ka venir dans meeting ici, Iglesia, ou vle sav côté tout le monde. Tout le monde ni pour la briver. What you making? A fashion statement?
Eh bien allez, quittez-moi ten.
Eh ben nous finissons un meeting dans Iglesia. Meeting ça, moi do about meeting now, right? Autant les yo passé que yo dit yo ni un meeting ici.
Oui,
You
moi
heard
t'en
of the
dis.
meeting?
Oui, moi t'en dis.
Yes. So this is what I am telling you, Iglesia. MHMC is having a meeting here tonight.
Cox,
Oui.
pour moi, ou dit OKEU, actuellement, on dit moi MNC, mani l'argent, mani au bas. Comment on a fait commission pour MNC?
Oui, messieurs. Là, mais moi plein. Iglesia, so pas tant M, ou pas tant H, là, mais autant MNC. Shop ouvre les shop pour pas mon rafon. We came to a meeting, Iglesia, and MHMC simply means Millennium Heights Medical Complex. This is the town hall meeting we are having. Papia shopping, papia semansi, moi beaucoup do emansi. Moi beaucoup do ça, pas bay selba moi souple. Moi do MHMC. Sou pas te connaître, mandez-moi. It's the Millennium Heights Medical Complex. Yo ki ni meeting na ici ya oswea Iglesia. Ou tant ça moi de bon chay moun kon ka kouye la OKEUH l'hôpital là. That is not the name of the facility, Iglesia. OKEUH is one facility there. Est-ce moi happy do e bon comprendre moi?
N'a koutou toujours?
Okay.
Continue.
Right. So now that I'm making you wiser, because if I cannot improve on your ignorance, I'll rearrange your intelligence. So, you need OKEU là. You need changer la talk, what was formerly la talk.
Oui.
You need ça là. You need turning point to changer turning point.
Oui.
Oui, ça là tout.
Yo ni tout ça là.
Complexe, c'est là complexe la sortie. So, après on des temps gouvernement parler dit VH, yo kay ni un pan VH aussi. So ça c'est quatre côtés yo kay conduit. This is why they call it the MHMC, Millennium High Medical Complex. Bon, où ça graduate à présent?
Actuellement, moi vini comprendre qui ça ou ka dire.
Okay then.
Mais moi confuse toujours.
Pour qui ça vous confuse?
Ou dit on bakay about VH?
Oui, Iglesia, VH Secondary Healthcare, Iglesia.
Qui ça qui secondary health?
Bon, c'est là où point moi. C'est pour ça que vous venez dans ton hall là, Iglesia. Là où il veut c'est mon dit demander question, demander yo question, but ça moi ça dou. Ou pas ça ma c'est bagay ou just aller VH. You cannot just go to VH. Now you will have to go to OKEU and you will be referred or somebody would advise that you go over there. Recommendations will be made. Ou comprendre ça moi ka dou là? Là yo ka conduire là.
Taleko.
Oui.
VH.
Oui.
Moi fait 5 each
5
VH.
Encore c'est 4 ish nou ni Iglesia.
Kok 5 each mweni.
Oh, moi ça c'est 4 mois. So ça l'autre là.
Ça moi teni avant moi.
Oh, avant moi. OK. OK.
Tout record docteur moi. VHI. Là moi fait ish.
Mais ben, mi record ou fait 5 ish.
Respiratory clinic là. Laiteye. Quand on dit moi yo kay tie VH et aller et puis.
Oui, Iglesia. Moi même pas pièce computer ou ka me top question. C'est pour ça yo ni ton hall meeting là où il veut que c'est moun di demander question ou ka demander yo ça.
Ay demander yo ça.
OK? Et yo dou pas intelligent. Ou demander qualité question kon. Qui ça ouvre savoir encore Iglesia?
What about say health center?
Bon Dieu, ça moi prier pour Iglesia, ça nous dia kay ni pour ni en ton hall nous dia. Iglesia, the health center is primary health care. Et yo kay parler about ça. Yo kay adresser ça. Mais ça moi ça dou c'est yo kay encourager moun souple. Son anti mal tête, anti mal boudin, pas plein OKEU. Ay un health center Iglesia, moun kon ka fait, moi ça vous ka fait. Mais c'est pas mal tête tourner ou juste kay fait ça fait moun dans l'hôpital.
Cox ou dit on bagay about health center on y pour aller avant. Depuis 4 health center a fait mais comment nous ka aller health center? Qui compte pas ça?
Belle question Iglesia. Mande yo ça. C'est pour ça yo ni ton hall là. Moi même jusqu'à ba information moi ni. Ou tant ça moi do là où il veut là, mande yo ça. Qui ça vous voulez savoir encore?
Moi non shy question ay mande yo. Parce que
oui,
Est-ce que OKEU ça là?
Right.
Les moun aller là. Pani oui med. Ou ka arriver là pani oui med. Ou ka assis ça sur une chaise combien de temps? L'autre moun qui vini après ou quand ou là ni on compagnie nos. Changer moi de ou en compagnie nos.
Pas tout.
Ma dou tout.
OK.
Bouche yo long. Kon bec. Balaou. Avant parler, yo ha parler pour mater.
Now.
Bon, moi hope tout ça kay changer en bagay ça là ou ka parler bot là hein.
Ah, c'est pour ça nous ni tong hall la iglesia. Et yo na bagay yo kuye chartered patients rights and responsibility. Yo kay parler about li. Moi hope kay écouter because ou même rights surtout pas tout avec bouchou. Les c'est moun nan commencer parler en tong hall la iglesia yo kay ba ou information ça. Yo kay dou kon moun ki kay prend traitement là, nos la ni pour venir adresser ou. Yo ka adresser ça. Do non. Ma do non, sorry. Et qui kay dou komuniye, il kay ba ou oui med, il kay dou ki sa oui med la yo ni tout ça est glacia. Ou comprendre moi? So ou kay ni right sou, right lan ka mande a, ou kay ni. OK? So bagay ba la ou ka parler là, ça pas nan rien pour faire épi. Ou comprendre?
Okay.
So yo kay adresser ça.
All right.
So qui ça encore? Ou satisfait ça kay fait ici
Oui,
frère?
moi d'accord. Moi même ni en qualité question à sous question.
Ou kay mande yo?
Oui.
OK.
Moi vini tout parler.
Ou vinn tout pa we?
Tout parler. Même quand Father Albert parle.
C'est ça qui te wete.
Moi dou ça.
Eh ben on y baka.
Et bon moi dou. Nous dernière question pour demander tellement reçoit ou même kaipé.
Vrai alors.
Oui.
C'est ça qu'a fait là Glacia.
Right.
So what's about bagla ou moi chebe?
Chebe bagla baby.
Oh, mais-
Moi quoi ici à te kay ni manger. Moi garder tout partout ma ouais pièce manger. Chebe bagla.
So c'est pour ça ou moi bagla
Oui,
Glacia.
moi-
Glacia, ou ayan le temps mon ka fait ça, ou vinn dans ton hall ou ka fait ça Glacia. Ou quoi ça right?
Cox.
Oui.
Behave comme. Bon,
OK.
écoutez moi.
Oui.
Nous parlons pour aller.
Oui.
Ou devant? Non. Moi qui devant. Moi ou devant.
Bon,
Moi devant. Ou derrière moi.
oui.
Now, flow, bow. Oh, oui, bon moi ça. Bon moi ça. Bon moi ça. Bon moi ça.
Chebe ça.
Bon moi, m'a oublié pour y aller. Bon
Ça
moi.
quand ça qu'on Glacia.
Question.
Question ni la qu'on Glacia?
Là, moi, des questions au soir. Moun nan ki CEO a. En vérité, il better venir good.
Font. Ça qui te dit moi mener Glacia ici à messieurs.
An ali.
OK, well moi
Moi
derrière.
devant, ou derrière, now, flow, bow.
Eh ben moi derrière. Thank you.
Now, flow, bow. I haven't heard that in a while. I haven't heard that in a while. Our favorite comedic duo. And now you know why it's important for us to laugh. They got some of the serious stuff in there. And I can still see that you are enjoying all of those jokes. So that's great. Thank you so much to Cox and Iglesia for that. Don't know why they're not married, though. Don't you think? They're like this really old married couple, you know? Love it. Maybe that's a side conversation we can have a little later on. Right, Cox? God, he's giving me an evil eye over there. We'll leave it there. We'll leave it right there. All right, so once again, let me just welcome you after all of this fun and to tell you once again that we are discussing life-saving matters. Cox and Iglesia did a wonderful job, and in this business of communication, there's never ever what we call an irrelevant question, stupid question, overbearing question. So she asked all of the relevant questions, and Cox, of course, gave her some pretty good answers. However, we want to get deeper into the matter, and we will be doing so, first off, with the chairperson of the board for the Millennium Heights Complex, Mrs. Joanna Reynolds Atherton, who is the chairperson. But before that, I want to be able to acknowledge all of you in the audience, but I want us to give a very special welcome to one of the special residents here in Babonneau. In our midst, we have the President of the Senate, Honorable Alvina Reynolds. We want to say thank you so much. We know that your schedule must be very hectic, but this is a great demonstration of commitment to community, commitment to improvement at all levels. So thank you so much for taking the time to come be with us. And we hope that you can also ask some questions. So that would be great. All right. So we now want to welcome Mrs. Joanna Reynolds Atherton, who is the chairperson of the board. And did I not introduce myself? Am I taking it for granted that everyone knows by now, you know, this voice and this face? Let me apologize. Lisa Joseph, happy to serve as your moderator for this evening. Mrs. Atherton, it's all yours.
A pleasant good evening, everyone. As Ms. Joseph indicated, I am Joanna Reynolds Atherton, the chair of the board of the Millennium Heights Medical Complex. I want to take the opportunity to introduce a few of our board members who are here. We have our CEO, Dr. Dexter James. I'll start with him because he's closest to me, and you'll indicate so they can see who you are. We have our deputy chair, Dr. Janice Stanley. And we also have, I like to call her nurse or director, Alicia Baptiste. Okay, so everyone wasn't able to be here, but we have good representation. The question you might ask is, why are we here? Really, these forums, and this is the third we have had, one in Grosley and one in Central Castries in the town hall. This is really an effort by the board to demonstrate public leadership and openness in the governance of the Millennium Heights Medical Complex. The meetings are really aimed to engage the public on matters related to the operations of the complex and to glean insights and recommendations from you on ways that the board can better serve your interests. In short, your voice matters. So this forum is about bringing power back to the people and finding ways to allow the public to be part of the process of delivering an improved service, an improved health service, that is. So it's really a genuine desire to engage you, the public, as we do not have all the answers. I want to take some time just to tell you a bit about the board and its work. So the board was installed just over 2 years ago, and it has been very busy understanding its own governance roles and functions while addressing matters of strategy and policy to guide the work of the management team. And some of the members of the management team are here, and you'll get to meet them a little later. I just want to touch on 4 or 5 major initiatives that we have been engaged in over the last 2 years. So one of the first orders of business was the recruitment of the CEO, and I introduced him a few minutes ago. And I want to tell you a bit about him. He took up office last October, that is in 2022. So Dr. James brings to the MHMC a wealth of experience in managing hospitals across the region, and having been in this business as a practitioner for over 20 years. He's a trained healthcare administrator, a professional accountant, and one of the leading experts in health reforms in the region. So we feel exceedingly fortunate to have him as part of our team. We have also focused on board governance, and since the appointment of this board, a number of standing committees have been established. These are really subcommittees of the board. We have a finance and audit committee, we have a staffing and compensation committee, and a quality and patient services committee. All of these committees are led by board members, and we are ably assisted by subject matter experts from within our management team. Another initiative is that of hospital accreditation. And you might ask, what is accreditation? Put in its very simple form, its simplest form, it's about achieving standards of excellence for delivery of healthcare service. And I won't go into too much of this because I am positive that the CEO will tell you much more about this particular initiative. Cox and Iglesias spoke about the MHMC Secondary Care Hospital. As you are aware, what was once VH, Victoria Hospital, was converted into the respiratory hospital during COVID. And now this facility part of this facility has been handed over to the Millennium Heights Medical Complex. The other half of the facility, or not half, but part of the facility, will be run by the Ministry of Health, and what we'll have is the Castries multi-purpose medical facility. This will be called, the Castries Urban Polyclinic, and it's an urgent care center. And then the other part is the secondary care hospital, which we will have responsibility for. This secondary care hospital in the main will provide additional beds for selected categories of patients, and it will help complement the services at what we call the OKU hospital. We also have a number of capital projects that are coming on stream, and one of the main ones is the commissioning of the oxygen plant. We have an oxygen plant established at the OKU hospital, and that plant will generate something like 60 bottles of oxygen per day, and that will meet and exceed the demand for oxygen at the OKU and other hospital facilities. We will also have the opportunity to sell oxygen to other healthcare facilities like the private hospital, and that will give us an opportunity to generate some income. There's also the long overdue laundry plant that is one of the services for the hospital, and that will be commissioned pretty soon. And we have other projects like the installation of a backup generator. There's some mold remediation works in the wards at the hospital and other inpatient services and wards. Another major initiative is that of providing a 24-hour hospital operations. So the idea is to restructure the clinical support services such as the laboratory, the X-ray department, and dispensing services. So these will operate on a 24-hour basis. So the whole idea of calling out staff in the middle of the night and during emergency situations will no longer exist. As it stands, the recruitment of staff is ongoing and should be complete pretty soon. These are just a tidbit of what it is that the board has been engaged in, the initiatives that we are currently implementing. And with this bit of information that I've shared, I want to thank you for listening, and I hand you over to the CEO who will elaborate on much of what I have indicated. Thanks for listening.
Are you going to leave me alone, Church? This is awfully lonely here. It's not moving. So, good evening to the community of Babonneau. I am Dexter James. I come to you this afternoon to speak with and to you with a measure of sincerity and truth. Our board has decided to embark on this outreach program as a way of connecting with our communities so that they become part of what we do at the Millennium Heights Medical Complex. It is an open admission that we don't have all the answers, and we rely on our communities and the constituents we serve to be able to say to us how they would like to see services develop at the complex. So this evening I will share with you who we are as a Millennium Medical Heights Complex, as our hospital services at a glance, some of our challenges. We know there are concerns about the accident emergency department. I'll share with you where we are today. Updates on the proposed development of the secondary care hospital and our focus for the next 24 months. Governance is about accountability, but good governance is the art of public leadership. This evening's presentation, therefore, is a demonstration by our board in this art form of public leadership. Who we are as the Millennium Heights Medical Complex, I'll just share with you a quick video so you get a sense of what the complex entails.
Did you know that Millennium Heights Medical Complex comprises a hospital, mental health institution, and a rehabilitation center? When the COVID-19 pandemic started in 2020, Victoria Hospital's operations were moved to the building of the O.N. King EU Hospital and was then merged with the National Mental Wellness Center and Turning Point Rehabilitation Center into one organization now known as Millennium Heights Medical Complex, or MHMC. This was guided by the Millennium Heights Medical Complex Act of 2015, which officially allows for the government to set up MHMC and its responsibility for its administration, management, and organization, led by a board of directors. Together, these three institutions on one compound now offer the widest range of services in the country, making MHMC St. Lucia's main healthcare institution. Call MHMC at 458-6500 or 458-6700, or you can email information@mhmc.lc for more. Follow us on Facebook and LinkedIn for updates at Millennium Heights Medical Complex and on Instagram at Millennium Heights Medical.
Was a did you know moment, because many times we produce a lot of good healthcare products at the hospital and the public don't really have a sense of what we do. So we are currently 122 beds at the OKUH. We manage the National Mental Wellness Center with 103 beds and the Turning Point Rehabilitation of 8 beds. A key feature here is that when we move from the former Victoria Hospital, we actually have less beds. The former Victoria Hospital was 150 beds. We are now occupying 122 beds at the tertiary care hospital called the OKEUH. Some key statistics at a glance, and this is the did you know moment. We see at least in excess of 6,000 patients per year, almost 15,000 outpatient visits, 18,000 at A&E admissions, and we manage about 94 patients on hemodialysis today. In terms of our diagnostic capability, we conduct about 19,000 imaging studies. We fill about 15,000 prescriptions, and we have about 14,500 physiotherapy treatments. So it's quite a busy facility. We do measure what I call the happiness factor of the constituents that we serve. We have a category of staff called patient executives, and all our inpatients, they meet on a daily basis and they ask selected questions. What is the relationship between the doctor and the nurse, the communications, the environment of care, the quality of the meal services? And we take these surveys in 3 settings: inpatients, outpatients, and the accident and emergency department. And we collapse that into a metric which gives us a sense of to what extent patients who access the hospital will promote the hospital as opposed to those who will demote it. In other words, what is the likelihood of a patient deciding to recommend a relative or friend to the OKUH as opposed to saying, don't go to that place? And we measure that in terms of what we call the Net Promoter Score. So this, for the 623 recipients that we conducted that survey for, in both the inpatients, outpatients, and A&E, the satisfaction rating of the population is about 3.8 on the scale, which is just about average. But the important feature is that 84%, or 8 out of 10 persons who come to the OKEUH have said, we will recommend our relatives and family to the OKUH as opposed to not recommending them to the hospital. This information, we tend to try to validate that by coming to town hall meetings of this kind and other types of forum to be able to validate this information. So this is independent information that is gathered from patients who present to the hospital that feed into our business intelligence software that we have that gives us this data on a real-time basis. So we are able to assess how hot or cold the environment is in both the inpatients, outpatients, and the accident and emergency department. I'll share with you in a bit what is happening at the A&E department. In terms of our run rate, another did you know moment, it costs about $90 million a year to deliver the package of services to the population of St. Lucia. And this gives you a sense of what the run rate is. $90 million is what we spend today to deliver the package of services to the population. What are some of our challenges? Well, we continue to face challenges with the shortage of nurses. It is being reduced at a declining rate now. We have high inpatient bed occupancy levels simply because our patients that are presenting are much sicker. We have the phenomenon of the NCDs, and I will share with you that data shortly. And then we face the issues of no-shows. This is a particular vexing issue for us because patients are booked for appointments, and we have 30%, 3 out of 10 patients are no-shows. They just don't show up. So this really creates a waste of resources for us because we have doctors waiting to see them in the outpatient clinics. They don't show up, and then at a later stage, they present to our emergency rooms in a catastrophic state. So this is an area that's a challenge for us right now. All our health services today face this challenge about the widening gap between the demand for and cost of health services and the supply of resources. Let's deal with the supply of resources. The supply of resources comes principally from the consolidated fund, taxation. It comes from donor aid. It comes from donations. Those 3 sources are compromised today. There's very little increase in those because of slow economic growth in most of our countries, sluggish economies, and the issues around contributions, the inability of the population to contribute. We have a smaller employment, persons in what we call the formal sector, and they're therefore able only to contribute only so much to the consolidated fund. But when we look at the top line, the drivers of demand and cost of health services is where the challenge really comes. And here's what is happening. What are those drivers? Well, we have the change in the demographic profile, an aging population, the disease condition, the emergence of communicable diseases, injuries from accidents and violence is a new public health phenomenon. And of course, we just came off COVID. All these are driving our healthcare costs. Perhaps more importantly, is there some factors that we call exogenous factors. And all that really means is that there's some costs that we have no control over. We don't control the cost of drugs and medical supplies. Whatever the market says is the price of drugs and medical supplies, we have to underwrite that cost. So that's 17 to 20% of the cost that we have absolutely no control over the cost. Advancing technology. In order to keep our tertiary care plant current, we need to invest in technology to make sure obsolescence don't catch us. All right? These are key factors that are driving our costs that we have no control over. There are other systemic factors. The waste and inefficiencies exist. 30% of the patients who are booked for appointments don't show up. So it means that the doctors who are supposed to produce work are not able to produce that work, and therefore that's an inefficient waste of resources. We see the practice of or malpractice coverage that is linked to the whole question of the litigious nature of our environment. Today, your hospital spends $620,000 a year for malpractice insurance. We have to spend it because things can go wrong, and in the event a suit is brought to us, we have to be able to mitigate it. overuse of diagnostics, and the practice again of this question of defensive medicine. All those are some of the drivers of cost that we are trying to control, but a challenge for us. There are other contributors, high public expectations, and the model of socialized medicine. Our populations are watching emergency room and doctor house, and they want all the fancy gadgets, including artificial intelligence. So those are high public expectations that we're grappling with on a day-to-day basis that we could ill afford to finance. Let me move quickly now into the Accident Emergency Department services. This is an area that is a make and break for us. The face of the hospital and the goodwill of the hospital is derived and determined by the public perception about what happens at our emergency room. Today, your accident emergency department sees about 1,500 patients per month. We categorize patients in what we call the ESI category, which is called the Emergency Severity Index. And all that means is that when patients come in, we sort them according to the emergency condition. This is not something that is well understood. And bear with me, I want to take a little time to explain to you how this ESI works. Who came into the hospital in order. Number one patient came in with runny nose. She does in fact have runny nose, but she came in with runny nose at 9:30. Number two patient came in with upset stomach. Came in at 10:15. Number three patient have been having this excruciating headache all day. And went to her primary care doc, and doc says, look, go to the hospital. She came in at 10:50. Number four came in at 11:30, stab wound to the abdomen, 11:30. And last one came in, motor vehicle accident at 12 p.m. So imagine this were the 5 patients who present to our emergency room. Look at the times they've come in. What the ESI does, and the nursing triad does, is that how do we select patients to be seen based on the severity of the medical condition? So help me here. Which one do you think should go first? Which one? You go to stab wound first? Serious travel injury. You want 9:30 first? All right. Nice conversation. So the vehicular accident in the triage is life-threatening. So we classify them as one, and that person has to be seen right away. Number one. The stab wound, again, life-threatening, may require to go to the theater, bleeding profusely, have to be seen second. Number 3, we don't know if this is an intracranial bleed or this patient might be a query stroke, so we got to see her third. These are 2 outliers that shouldn't be in the emergency room at all. But they present to us, so sir, we have to see them. So we will see the upset stomach next. And finally, we will then see the runny nose who came in at 9:30. Now, observe what has happened. And this is where we run into a lot of problems. The 9:30 and the 10:15 that came in earliest believed that they should have been seen and disposed of. But look at who was coming. So ordinarily what will happen, we will have to now deploy our resources to this measure of urgency. These are the patients that will have to remain a little longer because the conditions are not life-threatening. So this is what the triage is in the emergency room. It's a sorting of patients based on the acuity of the care and the question of the life-saving condition. It's not well understood. So what will happen is rush to theater, staying in A&E, stabilize them, and well, we've just given it some times, right? But even though these are the times they've come in, there are things going on in the emergency room in the back. They're resuscitating patients, they're intubating patients. But these are the times they've come in. So what happens is that the runny nose and the stomach, what we're saying is that these patients really should be using the network of our polyclinics and wellness centers for care. If they had used the primary care networks, it means we can now deploy more resources to take care of these life-threatening circumstances. This is the triage. It's a kind of love-hate relationship because the runny nose and the upset stomach, they love it because they got their medication and they got their diagnostics. But you know what? They hate it because they spend 3 hours and 4 hours. So these are the love-hate relationship. And they're the ones who speak out there about the negative goodwill and A&E. These three, they're all outside having some broken bones, but they are alive today because we were able to rush them to the theaters, emergency surgery done, and then they're all together. So this is a sense of how triage operates. And so it's not easy to understand because those who would have come in at 9 or 10 o'clock are still there all up until 1 o'clock. And they complain. And we don't do as well. We don't go out and say, well, here's the situation that we have. We just leave them there languishing. And we got to do better around that. We have to be able to conversate with our patients in our waiting area. Yes. Yeah. Yeah. Sorting. Yeah. Communication. Yeah. Yeah. But it's an interesting point here because in the science of emergency medicine, it speaks about a life-threatening circumstance that is real or imagined. So I could have a toothache that is brutally killing me, and I present to the emergency room. To me, it's a life-threatening circumstance. You understand what happened? That's it. So to me, it's a life-threatening circumstance. But when you present there and the A&E triage nurse sees it, oh, a toothache? Not really. So this question of emergency and how it is defined, it is really personal to you. This lady who's been sneezing whole day unconscious, she doesn't even know what's happening. And by the way, she's sneezing and her pressure went up. So to her, this is a life-threatening circumstance. So she presents to the emergency room. But when in the science of emergency medicine, when we triage it, it is not seen that way. So you've raised a valid point, and this is the tension that we have all the time. Public perception about what an emergency is versus what the reality of, in terms of the science of medicine. But, yes, sir. Yes, Father.
How can we know the extent of what is happening when you've not even looked at me? And that is experience.
Yes.
I'm not going to guess this. I get to the emergency, to ER or whatever you call it, and I'm not. You understand? And then you see some of them, their mouth long already. You understand? No, they upset as though they didn't get what they were supposed to get from home. And I am here, and I am suffering. So you are not even look at me, but you are telling me I have to wait. I mean, one time, I don't know what it was. I never knew Gary was so far from hospitals. When I got there, I'm afraid of hospitals. When I got there, I went straight in. I passed everything. I feel like dying. You understand? But if you are not even looking
Thank you.
at me, you cannot tell me this person's case is worse than mine. I understand, you may be under pressure, but at the end of the day, there needs to be clear communication. And I think just like the police,
Yes.
the healthcare, we need to train people in how to communicate with people. I was at OKU last week, Wednesday, and I encountered a nurse. Beautiful. Beautiful. You understand? Why we do not have, I mean, I'm not saying that our good nurses and charity. You understand? No, but sometimes, and it happens all across. Don't get me wrong. It happens.
Yeah.
Church as well. Some priests behave as though they're favor, they granted you. But we are there to serve. We are there to serve. And we can make it easier on the patients. We can make it easier with everybody, just how it comes to be.
Father, thanks very much for that.
Before you continue, CEO, let me just say, once again, let me reiterate. The presentation has a little bit ways to go again. We want to be able to get through and understand completely what's happening at the hospital. Just stick a pin where you want to be able to make the comments. And Father, I know you can. Father, I know you can. Let's just all say that prayer. And so just remember, take a little note. We all have our phones. Take your notes. And then towards the end of the presentation, we will be able to have a full conversation again with the CEO. Thank you. In the interest of time. Thank you.
Thank you for that. Thank you for all of that feedback. Those are real issues, real issues. And that's why we have these town hall meetings. All right, so let's move on. We tend to measure waiting times in the department. Focus on category 4 and 5, which is the cough and cold and runny nose. You would see, and the time there is in minutes, you would see under 1 hour, we process those patients who present to the department for triage. When we look at door to doctor, it's just under 2 hours for again category 4 and 5. Those are the ones who stay a long time or perceive long time because their conditions are deemed non-urgent. We have a particular, I don't want to say vexing issue, but because of the minimal beds that we have, on an average, on a daily basis, we have in excess of 25 patients who line on beds in the emergency department waiting for beds that we're not able to provide them. This really is a challenge for us. Are they getting the most appropriate care, the best appropriate care they can? Absolutely not. But we do the best we possibly can for those who are in our emergency room. So key challenges in the emergency department is the unavailability of beds. We're moving from 150 to 120 beds at the OKUH. Longer wait time. I mentioned there are about 15 to 20 admissions daily. A couple of weeks ago, we were up to 50 patients in our emergency room waiting for beds. And the last point is care provided in the wrong settings. That 25% that come to our emergency room for non-urgent care really should be getting care at our primary care networks, and therefore free our resources up to be able to process those more emergent type patients. Quick update on the secondary care hospital. As you know, the government has decided to repurpose the respiratory hospital as the Castries multipurpose medical facility. I refer to it as one facility, 3 services. And the 3 services to be provided would be an urgent care polyclinic, where the intention is they will discontinue or decommission the Castries Wellness Center and have those services now provided at the urban polyclinic. There's going to be an urgent center that will run from 8 to midnight, and then we are responsible for managing the secondary care hospital. What is transferred to us would be about 31 beds. We will have the infectious disease unit called the chest wing. We will have 2 operating theaters. We will have x-ray labs and inpatient dispensing services. It's our intention to make sure we develop these services that is second to none. Let me clarify the question of the notion of secondary care hospital. Secondary care hospital does not mean second-class care or poor people care. It is simply a different level of care. Just as we have primary care being the first level of care, secondary is the second level of care, and tertiary care is the highest level of care we could provide. So secondary care is really a different level of care, but it has nothing to do with second-class care. I just want us to bear that in mind. So we are taking steps to upgrade the facilities to make it as comfortable as it is at the OKUH facility. Where we are today, we have transitioned about 85 staff from the former respiratory hospital to our setting. We've installed an officer in charge. We now have patients at the chest wing. There were 9 patients at the chest wing today. And we just about very close to commissioning 12 additional beds and dispensing services at the secondary care facility. This will open up additional beds for us to be able to move a certain category of patient from OKUH across to that particular facility. So in closing, what is our strategic focus? We are moving forward in developing what we call the people-centered care. And the people-centered care really speak to engaging patients, families, and communities must be involved in and be participants of the care. It is no longer we delivering care and we saying to our population, take it or leave it. We have to engage our constituents to ensure that the services we provide are meaningful to them. And this is all embraced in the people-centered care. So it is developed in partnership with clients and family and with input from clients and family. Very new, very difficult for some of our stakeholders to appreciate it, but this is where we intend to go. Patient present to the ward, they must know about the diagnosis and treatment. We must be able to have family meetings and counseling. We must identify ourselves to the patient. Good afternoon, I am Nurse Brown. I'm here to do the dressings for you. Simple courtesy, that's bedside manners. So this is why we pursue in the people-centered care to be able to make that transformation of our care model. And we are adopting that as part of what we do. So our commitments to the people of St. Lucia, our commitment to Barbano, and every single citizen of St. Lucia is built around this. We're going to pursue hospital accreditation. We've already enrolled. We've had our self-assessment done about 4 months ago, and we're preparing ourselves for an accreditation visit in 2024. This is going to help strengthen what we do and improve the quality of what we do. We will seek to improve the patient experience. We've gotten 2 excellent responses earlier on. Communication. Communication. When patients talk about good quality service, it has less to do with the outcomes. What they talk about? Level of interpersonal communication between the patient and the caregiver. They speak about the environment of care. They speak about the quality of the meal service. Those are the soft things that patients talk about when they talk about the patient experience. If you judge the hospital on metrics around readmission rates, infection rates, etc., we're not doing badly. We're not doing badly at all. But when patients talk about the experience at OKU, is what Father has raised and this gentleman has raised. Communication. Communication. So a lot of our change process or change management process is getting our care providers to communicate. And it's not only doctors and nurses, from the receptionist to the cashiering to the person who deal with it. It's a whole mindset that we have to get changed out. We're going to strengthen our procurement function. We know a common criticism of the hospital is that they never have drugs. We're always out of drugs and medical supply. Well, let me just give you a bit of what is happening. The Central Procurement Agency for the country is responsible for buying drugs and medical supplies for the entire public health system. When on occasion their supply chain gets constipated, either because they haven't paid the bills or for whatever reason, the entire public health services is compromised. So what is the managerial response? Our board has taken the position that the limited resources that we have, we will go out there and buy some stocks and have them as buffer stocks available to us. I can say to you, in July, we have opened back our outpatient dispensing very quietly. We've dispensed about 375 prescriptions were filled. That's July. As of the data we've looked at for October, we've dispensed close to 1,500 prescriptions. So as we begin to take those tactical approaches, we'll begin to open back up the services that patients have grown accustomed to. It is painful, it pains me that when a doctor prescribes, that the only default we have to say, take this prescription to Massey. And we got a pharmacy at the hospital. It really is painful, and our quality committee has mandated that we set this thing up to make sure that that is a thing of the past. I'm happy to say that since July to now, we've begun to see some movement in our outpatient dispensing so that we could keep our customers a bit happier. We're going to finalize our regulations for admitting privileges, and what this will do is give doctors in the private sector an opportunity to use the theaters at the secondary care hospital to bring patients in, operate on them, and then they pay the hospital its fees. We'll commission the secondary care hospital. We'll develop hospital philanthropy as a viable approach for raising funds for the planned replacement of capital items. We will continue to strengthen our admissions, billings, and collections function, and we soon to establish a patient advocacy committee which will be the voice of the public that will serve as an independent entity of the public conscience. So we'll be coming to the community and ask you to nominate someone to serve on that committee, and that committee will receive complaints. They would meet with our board to discuss ways in which they could improve services, because in our small societies, patients tend to not want to complain openly to the formal systems that we have. And the reason for it is that there's the fear that the current and future care might be compromised. So they suffer in silence. And what we're saying is that we are setting up an independent advocacy group that if you feel so disposed, you can go to that group, lodge a complaint, and then they will send that in to us as a way of empowering our public to be able to have a say. You should not come to a hospital and if you feel uncomfortable with the service, feel that your future care will be compromised, you must be able to lodge a complaint and we could deal with it there and then. So we're setting up this advocacy committee, and you will hear something more about that in the next month or two, that will represent civil society or NGOs, the public. This evening we spoke about we want the youth to be part of it, we want women to be part of it as well, as a committee that will be served as the advocates for the public conscience in terms of how our services are developed. So this is all I really want to say to you this afternoon, and I'll be happy to field some questions on the presentation. Thank you very much.
Thank you very much, CEO. CEO, if you don't mind, if you take your mic so you can sit, the mic, you could just, yes, uproot it. There we go. So we've come to that time. I know that you are eager to be able to have the questions, right, Father Albert? And Father Albert is ready. Thank you, Father.
So I'm not sure if it's a question, but 2 points. And it goes back to one of the salient points that you've made when it comes to communication. So sometimes I've been at the hospital and you have a whole set of doctors and nurses sit down there, and it's like they're doing their own business and they're not communicating to the people around them. I think that is very bad. At least persons need to know, okay, yes, we will attend to you, we are coming to you, but we are dealing with that, we are dealing with that. It appears to me that, and sometimes I hear the conversation, it's nothing that have to do with what is happening around them. No, I'm being honest. I'm being honest. You know, no, it's true. It's true. The other thing, the last time I checked, St. Lucia is still a Catholic country. I get better reception when I go to Tapillon as a priest than when I go to OKEU, and I think that's an insult. Some of the securities, even after you identify yourself as a Catholic priest, that somebody has asked for you, they behave like they're granting you a favor. Now I have a little streak of ignorance in me. No, you see, because I don't have to beg to get into the hospital as a priest. And and it is one of the complaints that some of our priests have had. I think we had promised to write. I don't know if we ever wrote to the whole thing. But I think whether it is a Catholic priest, it's an Anglican priest, it's a Pentecostal pastor, it's an evangelical pastor, none of us should be challenged when we get to that hospital. None. It is our right, and it is the right of the patient who have asked to have time with the spiritual leader. And I think, you know, so whoever security companies that you all employ, they must be aware that when the priest, the pastor, the bishop, whoever comes for that, there should not be any time wasting, because their back and forth can cause somebody to go to hell. No, because the person may not make it, they may not be able to receive the sacraments while they're giving us a back and forth, and the person may die. You never know, because everybody wants the people to live forever, and they wait last minute to call the priest or the pastor. You understand? So for now, these two. Okay. Thank you very much.
But the CEO, before, perhaps let me just add to, if there's no other question on the floor, just a moment while CEO responds. Let me just add to this and ask, is what Father Albert describing sort of leftovers from the COVID period as well? Because patients themselves, persons going for outpatient clinic, there have been complaints as well from our patients that coming in, and even if they have the appointment date, the letter showing the date and so forth, that they too are stopped, they prevented, and even that there are errors. So perhaps they're not even on the list, but they can't even get past the security guard for them to get a proper explanation. So have we not been able to reverse some of those strict protocols that COVID demanded at that particular time?
All right, both good questions. Chair, you have left me, right? Both are valid questions. It boils down to customer service training. It boils down to as well, when you engage a third party to provide services for an entity, you have to make sure that they follow service quality standards befitting of the institution. It is only this week we've had that discussion, and I've said to them, all the private security firms, we have to now bring them into a customer service training program so that they operate under our service quality standards insofar as patient care is concerned. But Father, I want to encourage you as well. We do have a chapel that is grossly underutilized. Can't remember his name now, the Anglican priest in Castries, he came, he visited, and we really want to reinvigorate and get that facility up and running. We want it to be interdenominational for the Muslims, for the Catholics, for the Anglicans, for the Presbyterians. The facility is there underutilized. We've had early discussions about morning prayer and midday prayer and afternoon prayer. And we could alternate it. The Catholics might have it this week, next week the Anglicans. So that's an area I think you could help us in trying to bring that spiritual side to the particular complex. The issue you raise about access as a priest is a matter we have to address. I have asked the, I can't remember his name now, but he's in CCC, that we want a list of all the priests who are representing the various denominationals. Give us the names. We will get an access pass to each of them so that when they come, there's no issue in what you have addressed. So that is the approach we're going to take to them. We'll give them an access pass so that they can come to the hospital unfettered. Because you'll get a call 2 o'clock in the morning, 3 o'clock in the morning, and you don't want to come to the hospital and a security guard is frustrating you coming to deliver your last rites. So we take that concern, and we, as I said, our position is we'll issue a pass to each one of the various denominationals so that they could access the hospital as and when required. Yeah. Yeah. Yes. Right. And just use the card, make the card available to whoever is going to come. That's all right. Thank you, sir.
Any other questions on the floor? To the back. Thank you so much.
This time I'm not on the skit. Yeah, I did make the point earlier on, and I'm asking it now. What about, I realize there'll be changes, as you said, sir. This business of 4 o'clock, the health centers are closed. And with what is planning that you would not be able to come in because of, according to what you have, the running nose or whatever, you will not be able to be. So what about I have the running nose and at 6 o'clock, but the health center is already closed, or any other thing? What will I do? How would you, as the department, fix in this first place?
I think Mr. Coates has counseled you well. But you've hit the nail on the head. The unfortunate reality is that primary care is not under the Millennium Heights Medical Complex. So your example is bang on. You have the runny nose. It's now 5 o'clock. You really ain't feeling too well. Where does this patient go? No choice but to come to the Millennium Heights Medical Complex. So the begging question really is, are we really providing access to care? When we talk about access to care is not only the physical presence of a building. Access to care speaks to service level access, hours of opening access, service level access, etc. We cannot speak to what is happening at the primary care level. But what I can tell you is primary care is about building relationships. And so the facilities that lie within a catchment area must build those relationships with the community. So there ought to have been community meetings where matters of this will be discussed. Community will say, well, this is an agricultural community, and most of our farmers go to farm from 10. So we really want services that will run from 10 to 8 o'clock. So access must be driven by demand, not by what we as health professionals believe it should be. So this is the kind of conversation that we really should have to make sure that when we have our primary care facilities opened, they're open to serve the population, not to serve us. Because when we say it's 8 to 4, we're serving ourselves. So when you have the runny nose and the headache, etc., that you want to get sorted out, you have no choice but to come to the OKUH. That's where the love-hate relationship comes in. Because you know if you get down there, we have to see you. It may take 3 hours to see you, but you're going to get your prescription filled, you're going to get your lab work done, and if you need imaging studies, you're going to get your imaging studies done. So it's something that we will bring to our attention, bring to the attention of our Ministry of Health, that there's a need to look at this whole question of access again, across the board, to make sure that the services are really accessible and not necessarily the physical building. That is only one component of access. It's a very good question, and it is that lack of comprehensive access that creates a burden for the Millennium Heights Medical Complex. Because these are patients who ordinarily should be seen at the primary care level, but they then present to the emergency department for care.
CEO, I know that the Castries Urban Polyclinic is not our responsibility, but to a certain extent, won't it provide that after-hour service, at least in the Castries Basin?
Yeah, so when the urban polyclinic is set up, the urgent center is set up in this facility that we're speaking about. The intention is to run that facility up to midnight. And hopefully that will take the pressure off okay, we can't wait for it to happen, because it's going to have there's going to be diagnostics, which we'll provide. There's going to be dispensing services, which will be provided by the ministry, and there's going to be laboratory services. So it means if a patient presents up to midnight, they can be seen and treated. And if per chance they have to be admitted, the secondary care hospital is right there to get admitted to the hospital. So this facility will provide us with this opportunity to deal with the access issues that Ms. Coates raised a while ago. Thank you, Chair.
Any other questions on the floor? We have the President of the Senate. I knew she wouldn't disappoint.
Good evening, everyone, and let me take this opportunity to thank the management and staff of the medical complex for taking time out to come up to our community to engage with the residents. I know you've had a long day, and we'll try our best to get you to your homes as quickly as possible. Dr. James, a few questions. One, a rape situation. a victim of rape reporting or being brought to the hospital, I have been informed that it's not seen as an emergency situation, and the victim is asked to wait for hours on end for processing. And of course, you need the evidence for the court case. Is there anything that can be put in place at the hospital to facilitate a speedy or urgent processing or dealing with a rape victim and giving that lady or gentleman that kind of support, because it's needed psychologically and medically? So is there anything in place? Do you want me to give my 3 questions on one go, or do you respond and I come back with my other 2?
You want to take?
Your response is concerning. A rape victim presenting to our emergency room, by no stroke of imagination, cannot be seen as an emergency condition. So, however that would have occurred, the system erred if there is validity towards it. And yes, the issue you've raised about the psychosocial support is part of that people-centered care. I mean, how many times a patient presents to our hospital? See the doc today. Gangrenous foot, I'm gonna cut off your leg. Let me see you on Friday. That's it. Who is taking this patient from anger, denial, depression to the point of acceptance? We oftentimes don't see a prescription written to go see the psychologist. This is why the people-centered care is so important to us, because it's not only about the medicine and the diagnosis, but it is the humanness and the human side of care that we need to be concerned about. A rape victim presenting to our emergency room cannot, by any stroke of imagination, be seen as a cough and cold or headache. That's an emergency condition that requires urgent medical attention to swab and etc. The police has to be involved in it, and moreover, such a patient must be traumatized. So the need to provide them with psychosocial support must be part of the entire treatment package. So that is an unfortunate situation, and if such a patient did in fact have to endure that, that's something that I certainly would like to know personally so we could investigate that. That is really not in keeping with the algorithm for how you treat a patient presenting that traumatic situation.
But what exactly is the system in place? Because this is a very important issue that Honorable Alvina Reynolds has raised. You mentioned, of course, the police needs to be notified. What is the response time for the police to come in on a matter like this, if you know? What exactly is the system in place to ensure chain of custody of those samples that would be taken, because it's going to be a criminal matter? And so there are certain steps that would need to be taken in order for you to be able to preserve all of the evidence and at the same time ensure that the medical professionals can do what they need to do. So can you give us, if you can, a little insight look as to what system is in place for such cases?
Well, first of all, the patient presenting in a triage category would clearly be a category 1 or 2, in fact, category 1. So they would have gone inside the emergency room right away. The healthcare provider will discuss with them the situation, and right there and then we begin the swabbing, right? That goes to our lab. Immediately we have to notify the police. Generally, the police don't take very long to come. Once we notify them that we have a rape victim, we address that. The psychosocial support, I will admit, we tend not to make that mandatory. But this is why this process of the people-centered care is important. because we have to recognize that that must go along with the treatment package. So in short, that is really what we do. We will provide free of cost to the patient. We have our psychologists who meet with them, and we work through with them the number of sessions to deal with the social, with the emotional impact that will have caused them. But this would have to be treated as an emergency. This is why I'll be interested, President, right?
Yes, yes.
President,
Yeah.
to afterwards, give me the name of the person. I would like to have a chat with them to find out really what has transpired. Because we are an organization of learning. I need to find out what went wrong so we could now find out in our emergency department what transpired with respect to this particular case and take remediation actions to make sure it doesn't happen again.
Okay, thank you for that. Second one is almost similar. Because it's a complex, someone may be suicidal and they have to be assessed as to whether it's a medical situation or psychological. So there's a chain of command, I know, so it takes a bit of time. And I had the experience where a young lady was suicidal and she was taken to the OKEU, had to be seen by a medical professional so that she could be either taken back to mental wellness. And Doc, that took forever. It took forever for that young lady. In fact, she left. I had to be on the phone for all hours of the night. I had to send lunch to her and dinner to her to make sure she stayed there with her baby. And people were just walking up and down. So I'm just saying that, so these are little things, because I know the chain of command. But again, as Father and Murray has mentioned, it's communication. Somebody needs to explain to the patient, to the customer, to the client, as to why they have to be seen by a doctor and not taken straight to the home for abused women or to the turning point or wherever. The protocols must be explained to patients so they can have an appreciation for it and to not give the staff stress. Because if they don't know, they are going to flare up and you will have a bit of back and forth in the system. You mentioned that there are persons who are given dates to come in for their appointments, but there is a no-show. And then they appear with an emergency situation or something that's very extreme. My question is, I'll give you the back-to-back, whether the board has looked into what prevents clients from keeping their appointments, because when they come in at emergencies, more problems for the hospital at this point in time. Have you and your team investigated what's causing that in an effort to address it? And the next question after that is beds and the capacity. I don't know, I can't remember whether you said how many beds the Victoria Hospital would have. But I remember that there is supposed to be a fifth finger to OKEU. Has the board of directors in the strategic plan, etc., consider if it is possible at all to construct the fifth finger to the hospital to help alleviate the problem of beds at the hospital?
Thank you, President. So the question of hospital philanthropy is where we hope to drive that capital improvement. So the intention is to develop a prospectus and launch the prospectus under a different kind of arrangement. Our board is now looking at setting up the Millennium Heights Medical Complex Trust, which will be a special purpose vehicle for raising funds to deal with capital projects that we have raised. Once that trust is set up, we set them afoot to go out there and raise funds to construct the fifth wing. And yes, the fifth wing will certainly be part of that prospectus to give us some additional beds to now complete the fifth wing of the entire complex. We estimate that we should get at least 24 to 30 beds if we're able to get those beds purposed. That certainly will enhance capacity at the complex. So the point is well taken, and it will be financed through philanthropy. Our board is concerned about the state cannot provide all the funding. And so we are finding very creative ways to be able to raise funds to meet the needs of the capital improvements at the hospital. Not the recurrent, for paying salaries and all of that, but certainly capital improvements is one of the ways in which we see we could address it. And the first question?
The other question pertaining to an investigation as to why patients are not keeping their appointments or patients.
Yeah. So we have a process in place that says 48 hours before your appointment, our admissions office will call persons reminding of their appointments 48 hours before. So that is one of the measures that we use for trying to minimize the no-shows. But there are various reasons that people give. They either forgot, the day in question, there were some exigencies that they couldn't meet their appointment. Maybe there's the view that you have to pay this $20 to your outpatient clinic. On that day, you don't have the $20 to pay. There's a plethora of reasons. We have not investigated the veracity of any of those reasons. But what we do know is that we've done what we feel is necessary to make sure we remind you. Very shortly, we'll be working with our IT partners, ICT partners, to be able to send not a WhatsApp, an SMS message to remind persons who have mobile phones of their appointments. But it's an area of inefficiency. It's an area we have to address, because with such a high level of no-shows, it means that there's a waste in human resources. Our doctors, our nurses, and everybody is there, and there are no persons who are showing up. So it's a valid concern, and it is really right for further investigation to find out the why are persons not showing up.
Thank you very much. Can I just answer this question, assist Dr. James with this question? Madam President, I think we probably need to identify Madam President as the former Minister of Health. And so her questions are hard-hitting and very pertinent. Yes, in fact, Madam President, the board has considered many of those, reviewed many of those questions that you've asked. We acknowledge the need for protocols, but protocols that the staff is well familiar with, so that the process can be properly executed in the time when it's needed. So we will take that on board. They're very good areas of concern. In terms of the question on why there are no-shows, I think the board has taken up, the board and the management, in fact, have evaluated the reasons for that. Directly, the committee, the Quality and Patient Services Committee, is directly addressing that problem. We've dealt with that over the last few months, and many reasons come up. And some of them we do understand, and what Dr. James has told you is what we have been doing to address some of them in terms of the calling of the patients. In the past, there was never a proper structure in place where we called the patients to follow up for their appointments. Patients came in on the same day of their procedure. Sometimes they have not paid. Other times the bed has not been found. So essentially, there are reasons, for example, that the patient may have been seen. So establishing this mechanism in place where we can call the patient ahead of time and prep them, and in the event that there is no, that they are not going to present for the appointment because they have attended somewhere else, because, you know, we have lost some, whatever the reason is, then we can now, in order to take advantage of other patients on the waiting list and reduce the wait times, this is how this has helped us and this is how it's going to help us. So we've taken those things into consideration, and yes, we are assessing the various reasons for the no-shows. So while Dr. James has mentioned them, it's really just to identify to the public that this is a serious, vexing problem for us, and that it is also their responsibility, if they're not going to present for an appointment, that they too can reach out to us, because we need to work together more effectively to to present a better service to them.
We have a question to the back. Any more questions, comments on the floor?
Yeah. So, Dr. James, I wanted to give some insight, say, from someone who has used the service, the outpatient clinic service of OKU, to indicate that probably the management of the appointments needs to be looked at. Currently, an appointment date and time is given for an outpatient clinic, and when you get to the hospital and you pay the fee, the wait time is still very long. Most times it is not the time that you were told. So I've been given appointment times of 9 o'clock, and then I got in at 8:30, did what I had to do in terms of payment, and I'm waiting. Okay, 9 o'clock comes, and then that particular day, I didn't see the doctor until after 12. I mean, these things breed frustration. Now, when I complained, immediately when I got into the doctor's office, I said, hey, this is totally unacceptable. I was told to come here at 9 o'clock. I came before time, but I was expecting probably, 9:30, at the latest. And then she said to me, hey, this time, forget about that. That time does not work. It's first come, first serve. Again, communication, but I don't think that the system works very well. So when my subsequent visits, I've had to just tell myself I'm going to be spending the whole day at the clinic. And essentially that's what has been happening. No matter how early I come, I still have to wait a long time, and then I get the impression that persons who came in after me, because I got to the clerk before them, they are getting to see the doctor before me. I mean, these things, for some people, they may not worry too much, but I think I deserve better. And as a patient, we all deserve better. So I think that the issue needs to be looked at, so at least to remove some of that frustration. That if I was not dedicated to getting my recovery well, I might have skipped quite a few of the subsequent appointments.
Are you familiar with such complaints, Doc? And why would we have that sort of bottleneck and delay?
Well, it's a valid concern raised because of the high level of no-shows. What the docs have done now is that they've overbooked the clinics just to make sure that they have enough patients, right? It's unacceptable, but because of this high level of no-shows, they book more patients than is required. I want to say that the start times of the clinics is not something that we could defend, but it has oftentimes been preferred to me that clinics sometimes start late because the doctors who have to run the clinics are doing wrongs, meaning they have to go and see patients first before coming down to the clinic. And in particular with internal medicine, that is a fairly heavy specialty, you find that the rounds take a little longer. So a clinic that is supposed to start at 9 o'clock now starts at 9:30 or 10 or even 11. So everything gets pushed back. This has been brought to the attention of our consultants, and it's an area we're asking them to seek redress, because if you book appointments to 9 o'clock and patients get there for 9, having them there until 11:30 creates a problem. So your concerns are valid. It is a truism that it does in fact exist. But we have to deal with the inefficiencies that exist in the overall system. The no-shows, the booking more patients than is required to make sure you have enough patients, and the need for us to keep on time with as close of our appointments is also an important feature. I have thrown out to some of my colleagues, I know it tends to be contentious, but hospitals don't run 8 to 4. Why is it not possible to have a Saturday morning service? So everybody get quiet in this room. Why is it not possible to have a Saturday morning service? So you streamline your clinics, and therefore you don't have these bottlenecks taking place. Well, they said to me it's a resource issue. But it's frontally in my head because it seemed to me that if you, instead of booking 20, 30 patients in a clinic, if you recommend to run a half-day service, subject to getting nursing available, persons come at their own comfort, it's quieter, and you streamline the clinics. One of the areas that we're very sensitive to is the question of cancellations. We're not talking about persons no-show now, but where we have canceled patients either because we are unable to make it on the day, or because we have wrongdoing taking place and we have to cut off the clinics, we said to them that those patients must be rebooked in the earliest appointment, perhaps in the same month. The situation where cancellations, we say to patients, go and now rebook. And then the next available booking time is January next year, is unacceptable. So we're trying to put a protocol in place that says any cancellation that takes place in the month, those patients must be seen in the month or in the next available period in the following month as a makeup clinic. So those are some of the nuances we're trying to address to make sure, again, the people-centered care approach takes precedent over our own personal interest.
Does the issue also speak to pressure on staffing? So what is the complement of your staff, and is it sufficient?
Well, we are currently, in terms of nursing all told, we're just about 100 nurses short. But our committee is looking at what we call changing. We have to change out the skills mix of our nurses. To date, all we have is registered nurses and health aides. Most hospitals have what is called registered nursing assistants. So we're going to be working with the Sir Arthur Lewis Community College in asking them to design a program to begin to train St. Lucians as RNAs. If we're able to change that out in the next, say, 2 years, 2.5 years, it means we'll now build capacity within the system and be able to provide a much more robust nursing resource. But right now, we have RNs, and the next available category of staff are health aides. There's no middle tier, as most hospitals will have here in St. Lucia. There's no hospital from Trinidad to Bermuda that don't have registered nursing assistants as part of its nursing mix. So our committee and board is committed to working through that in the next 2 to 3 years. We'll be working with the Sir Arthur Lewis Community College to design a program to allow us to be able to matriculate RNAs to be able to start to build out a new skills mix within our nursing cadre.
And what about your doctors? Burnout, because that is something the doctors often complain about, the hours that they have to work. Sometimes you leave the hospital, you're back on call, an emergency has occurred. So how are we doing in that, and are there the plans to buffer as well?
So like nursing, most in the hierarchy of medical professions, you'd have a consultant, specialist, you'll have a registrar, and then you have house officers. For most of our disciplines at this hospital, we have a consultant and house officers or registrars. So the middle-level area is very, very weak. We have to build that out so that when consultants come around and they leave, the senior registrars who postgraduate qualified are the ones who will run the facility. So the question the gentleman is raising, if we had senior registrars, there would not be the imperative that the consultants have to see him in the outpatients. The senior registrars could have seen him because they're postgraduate qualified, and the consultants could then see perhaps all the post-operative patients. This is a higher level of care. So in terms of our medical services, we have to look carefully now at our structure. The NCDs are here with us. And if it's one area that we need to attack very early is in internal medicine, to see if we could build out that middle-level group to have a few specialists called senior registrars, least so with surgery. All right, so that is the issue. It's going to call for more resources, and as we begin to evolve the system, once the resources are provided, we'll seek to develop going forward.
Big inefficiencies there. Okay, I'll get back to that question. Let's go to the floor.
Thank you. So the question you've raised about sizing of hospitals, and this is not a St. Lucia phenomenon. This has happened across the region where hospitals are built. Planners and hospital architects will size hospitals on the premise that primary health care is working well. I can give you an example. In Trinidad and Tobago, we moved from one facility, 260 beds, to 100 beds. And the assumption was that primary care, while a hospital was being constructed, will take up the slack. If those assumptions don't hold well, the hospital was too small. So today in that particular facility, The 100-bed hospital is bursting at the seams. So when we speak about the re-engineering of our services, and we speak about it being built around primary care, if we don't address it seriously, it will come back to roost. It will come back to haunt us. We are not there yet. But if we don't take urgent steps to address and remediate the problems at our primary care level, let us start to build another OKEUH in the next 5 years. It is going to be too small. The phenomena I presented here to you that showed that there are at least over 25 boarded patients in our emergency room every single day. Not some days, every day. And these patients are the uncontrolled diabetics, the uncontrolled hypertensives, those presenting with heart problems, and then, of course, there's the issues of injuries from accidents and violence. These are public health issues that are here with us now. So sometimes when we go to these town hall meetings, you'll oftentimes hear me as a practitioner speak a lot passionately about primary care. It's not about hospital business. If we begin with the end in mind, what we've seen at the Owen King European Union Hospital today speak to perhaps failure or failings of our primary care network. This didn't just happen. So more attention needs to be given to primary care. We're not diluting the work that they're doing. They're doing a lot of work, excellent work. Are they doing enough? Perhaps not. And this has to be addressed nationally if we're going to fix this problem. If tomorrow we're able to wave a magic wand and build out the fifth wing, it wouldn't be before 6 months' time that that fifth finger will be at full occupancy. You understand what I'm saying? So the resolution of the problems for the OKUH resides on the extent to which we get our primary care system working and working well. The chronic care model is the predominant model that is used to deal with chronic diseases, and is built around certain indicators: community participation, patient empowerment, health information systems, decision support networks. How many diabetics could say that they receive 4 basic tests every 6 months? HbA1c, a foot study for dietary, a fundus study for eyes, and lipid profile. Those are the basic algorithm for treating a diabetic. Do we have those protocols being implemented continuously for every diabetic? We are not able to say, but from what we see at our hospital, we know something is not happening well out there. Decision support systems, that's what it is. We set up these protocols, and our DMOs must follow them. Every diabetic that we have in our registry must be able to get these 4 tests twice a year to be able to monitor their markers to make sure that they're properly controlled. But if you don't have centers opening with the flexibility that the gentleman raised in the back, and at 4 o'clock we have to close the door, and we don't establish standards that say every patient will have at least 15 or 20 minutes consultation, then we shoot ourselves in the foot. It's not about when the known diabetic is coming through the door, we start to write the prescription. It has to be a genuine engagement to the patient to find out what is wrong with them. It might be a situation where they're unemployed and therefore not able to have a good diet. It might be a domestic problem affecting them. Listen, I spoke to a primary care physician once. We put in place a national health insurance scheme. And she says to me, look, when a patient comes to me, in the first 5 minutes, medically, I know what's wrong with them. But the next 25 minutes, I have to spend discussing everything outside medicine. I have a teenage daughter stressing me out. I have a boyfriend hitting me. I can't buy, medication on time. And she says, that's primary care. She has to listen to it, because if you just dismiss the patient, give them the prescription and they leave, you have not dealt with the root cause of the problems that the patients face. Now, that could only happen if you have a different model as to how you deal with primary care. It can't be how it is set up now. It has to be done differently. So the models that we have in the past are not the models that we need now to solve our problems. So the resolution of the inpatient problems for the OKEUH really resides on the extent to which we're able to fix the problems at the primary care level. And we must be part of the solution. So ought we not to be sending specialists out there to have specialist outpatient clinics? So that the high-risk patients seen at your wellness centers here, on the third Thursday of every month, they could see the internist, they could see the nephrologist, they could see the general surgeon. That is the kind of changes that we need to make. Rather than say, get sick out there, present to the emergency room, and we provide the best amputation that we possibly can. That is not what it is about. So unless we have to create a forum to be able to start talking about this more, then my fear is that the bed management issues is not going to be solved in the short term, nor even the medium term.
Any other questions from the floor? We're about to wrap up. If I'm going to beg your indulgence for 5 more minutes, and I'm going to ask the final question to Dr. James, and I think it's a little ribbon for the bow on top of everything, and we'll speak to sort of a way forward for the OKEUH. Accreditation, you spoke about it during your presentation. You also just a while ago explained the deficiencies that we have in our human resource capacity. And I would think that would have some footplay in the accreditation process. So explain to us what the accreditation process would mean for the hospital in terms of being able to shore up certain systems, in terms of being able to go out there and source in funding as well. Would that help us in any way at all? And what does it really mean for the overall care and function of the hospital?
Thank you for that question. Let me just say the pursuit of hospital accreditation is not an esoteric exercise. Hospital accreditation is a process by which a hospital is compared to best practices to be able to identify the gaps in practice. So the pursuit of hospital accreditation allows our board to identify where are the gaps in practice standards for the hospital. And those gaps are what we're going to use to improve the quality of what we do. Accreditation is about quality improvement. This feedback that we've received today is really valid feedback. We have to use this now and decide how we're going to plan, do, implement some of these changes, and then evaluate it down the road. It's a continuous process. This process has opened up options for us, but it's also exposed the nakedness as well. There's some practices that we had for a long time that we felt we're doing the best things in sliced bread. Only to find out that when accreditation has come, it has identified those things that we're doing well and those areas that we're not doing so well. So the process is a noble one. It is not how we feel, but it is what is the best practices to improve the quality of care to our patients. For us to date, we really want to get that last bullet, the Patient Advocacy Committee, because we feel that patients and the public and communities must have a say in the way services are delivered. We generally want to hear from patients, the community, and visitors. We don't have all the answers. This afternoon, about 4 or 5 solid recommendations came out that I'm sure our board will take on board. And it is through these engagements that we'll be able to make the changes to the hospital. Sometime next year, we'll come back to the Babanu community and say, these are your concerns that you've raised with us. This is what we've done to correct it. And these are the improvements that we've seen. It's all about community participation. So this is not a cosmetic exercise. This is not a pseudo exercise. This is a genuine exercise to communicate and engage our population on the way services are delivered, with the sole intention of improving the quality of care to our citizens.
Thank you so much for that. And we've come to the end of the 3rd installment in the Town Hall series for the Millennium Heights Medical Complex, the manager operators for the Owen King EU Hospital. So we do hope that the session has been informative. I did promise you that at the very top. We did say that it's going to be about life-saving matters, and yes, we had a lot of discussion on that. So we want to thank very much, once again, Honorable Alvina Reynolds, the President of the Senate, and of course a very proud, how do you say it? Is it Babu? Oh, boy. I'm not even going to attempt. That's why she's at the head of it all when it comes to the activities here in Babano. We want to thank you once again, and of course for your very probing questions as well. And I didn't want to initially, identify you as a former Minister for Health. I didn't want to put Dr. James under any pressure, but she did, but he handled it very well. So thank you once again for coming and, of course, for sharing your knowledge as well. We want to say thank you very much to Mrs. Joanna Reynolds Arthurton, who is the chairperson for the board for the Millennium Heights Complex. Thank you for your insight, for coming, and for being able to realize you were taking some notes. So it means that you are going to ensure that the board keeps it up, and so that they can address some of those matters coming out of this evening's session. Also, we want to say thank you, Dr. Dexter James, the CEO. Thank you so much for your commitment, your dedication, and you have such passion for what you are doing. So thank you so much for being able to lead. Thank you so much. We also want to acknowledge Dr. Stanley Shaw. Thank you so much. He is the deputy, the first name is Janine? Janice. There we go, Janice. Thank you so much for being with us. She's the deputy chair of the board. We want to also acknowledge Nurse Alicia Baptiste. Thank you so much. She's a member of the board, or director on the board. Thank you for coming through. Thank you to the HR consultant, Ms. Euriska Chandler. I hope I got that right. We also want to say thank you to Mrs. Danine Jones, Nurse Glenda Sepal, Father Albert. How we can forget? Has he gone because he has a curfew? Okay. Thank you so much, Father Albert, for the prayers and for the insightful comments as well. Thank you once again to Ms. Evelyn Alcide, who is the Deputy Manager, Employee Engagement. Lots of work being done on that front. And last but not least, we want to say thank you to Cox Productions, Serial Productions, Cox and Iglesia. Thank you. It was wonderful. We'll be doing it again soon, I think. And all that's left is for me to say, on behalf of myself, thank you, the wider audience, for coming. Thank you for those of you who joined us virtually. And we do hope that you can go back and click. There are 3 sessions. Go back and click on each of them and watch. I guarantee you that you'll be hearing something new every time you will watch one of these sessions. I am Lisa Joseph. I've been very, very happy to serve as the moderator for this evening. And the technicians, oh, how can I forget my namesake to the back? Jeremiah, thank you very much. And of course to our comms, communications, thank you very much, Dave Charles. He's always very hardworking and always in the background. Thank you for ensuring that everything has gone smooth. And to the wider team at the Millennium Heights Medical Complex, thank you so much for all your hard work. It's not said enough, but don't worry. Christmas are come. You're going to get some goodies. The CEO...